At a certain point on today's episode about hearing loss and cystic fibrosis, you might notice a faint, persistent beeping in the background. Yes, we know it's there, and actually it's my diabetes pump alarm, kindly trying to get my attention throughout the recording. The irony, I couldn't hear it because I have high-frequency hearing loss. We couldn't edit it out, so we're embracing it. Another unexplained tech issue? You'll notice Lauren is just a voice this time. We had a little technical hiccup with the video recording, so please enjoy a fun photo of her and her dog Bowser instead. Consider it all a real-world remix of chronic illness, notification fatigue, and tech that isn't always assistive. Enjoy the show. The content provided in this podcast is for informational and educational purposes only and is not intended as medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.
Is it my story, your story, his story, her story, Jane's story, Joe's story? Is it just an allegory? Show's about to start and we still don't have a name for it. Bop, 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 bop. It's a long story.
Aging and cystic fibrosis are words you don't always hear in the same sentence, but on this podcast, you'll hear them all the time, with relevant discussions and unexpected explorations wherever this podcast might take us.
So many people with CF are living longer thanks to modulators and medical advances. We thought it was time to get into some real conversations with expert guests and people from all walks of CF about what living longer with CF means, the good and the not so good.
I'm Dr. Ahmet Uluer.
And I'm Lauren Harvey.
I'm a medicine and pediatric trained pulmonologist and director of an adult CF center at a Harvard-affiliated hospital right here in Boston.
And I've had CF all my life and was recently diagnosed with CF-related diabetes. I am committed to creating a supportive space for those with CF and their loved ones.
I will bring the medical expertise and provider perspective.
I bring the real-life CF experience.
And together we bring you It's a Lung Story, a monthly podcast about aging with cystic fibrosis, where we take a little time to tell a lung story.
It's a long story.
It's a lung story.
Nice improvement over the first time.
Beautiful.
Thank you. I was learning from you guys. You guys have done the second and third ones so nicely. I thought I'd have to, bring it up a notch.
You were learning off my off-pitch version.
How many times did you practice?
Just the 3 times. And so, so 3 makes it perfect. So first of all, we should keep going here and say welcome to our 5th podcast, because we had a part 1 and part 2 that made that episode 3 and 4. So welcome to podcast number 5. And we appreciate everyone being here, and we look forward to you meeting our incredible guest today. But I also wanted to just start out and just see how everybody's weekend went. It was Mother's Day weekend. I hope people were able to do something nice with their moms and enjoy the nice weather if you were in a place where there was nice weather to be had.
Well, there was certainly nice weather here in Boston, where I spent Mother's Day with my fabulous aunt, who's also a mom. And we didn't do anything special except we each had our own individual bowls, super bowls of ice cream, and watched the end of The Pit.
Oh, that
sounds awesome.
Mm-hmm.
Super
Yeah,
relaxing. Sometimes the relaxing ones are the best ones.
It was just fabulous for her and for us.
I know, Lauren, you're pretty far away from your mom, so I don't know if you got to spend it with other moms.
I actually got to spend it with my boyfriend's mom and the rest of his family because his
nice.
younger sister graduated college. So we actually spent the weekend in Boise, Idaho, and it was awesome. I had never been to Boise, so I got to explore a little bit, and it was a fun trip.
And you drove from Portland, Oregon to Boise, Idaho?
Yes, and it
Wow.
was about 6.5 to 7 hours. A little bit of a painful drive. Wasn't very enjoyable, but it was beautiful scenery, very windy. So we have a small car and it did not enjoy that. But otherwise, it was a great trip. And, we switched off driving, so it wasn't too bad, but definitely not wanting to do a road trip anytime soon. I definitely need a break.
Yeah, and I clearly need to look at the map of the U.S. to see exactly how far Oregon is from Idaho. But I'm glad that it was only 6.5 hours. In my head, it was like 12.
I wouldn't do it if it was 12.
Yeah. Well, I went to upstate New York, and I had a great time with my aunt-in-law, who is really my aunt. She's lovely, and she is this fabulous woman. I'm so glad we got to spend it with her. But I want to talk about something that most people don't know they want to hear a lot more about. And that pun was not intended, but it's perfect for this podcast because we're going to be talking about hearing loss and the risk of having CF and how it affects your hearing. So we are really lucky to have our guest on today who is really positioning herself to be the foremost expert in the field. And we're just so lucky that she's joining us today. And I called her my Greek sister because we do share some, we absolutely have some shared heritage. My family on my mother's side comes from a city called Thessalonica, which is on the east coast of Greece. And so I'm guessing there's something way back there that, connects us because she's really amazing. And when we talk about our families, there's just so many similarities. But I would love to introduce you to Dr. Angela, or we're going to call her Angie Garinis. She's an associate professor in the Oregon Hearing Research Center at Oregon Health and Science University, very close to Lauren. And she's a licensed clinical audiologist and is just an expert on hearing loss, especially hearing loss and balance disorders caused by medications and specifically aminoglycosides. We'll talk about that. Those are antibiotics that are used pretty routinely for people with cystic fibrosis, or at least they were. So welcome, Angie.
Thank you so much, Ahmet. Thank you all for having me today.
No,
it's always a pleasure to do something with Ahmet. Thank you.
Oh my God, the pleasure is like all on my side. We want to start off our conversation on a topic that often, I think of it as a relationship killer. Because when we started talking about you and asking you to be our guest, and I'm so glad you accepted, but we were talking about our relationships with our significant others and how sometimes we are frustrated. And on my end, it's the opposite. My wife is frustrated with me that I will ask her to repeat something and she just feels like I wasn't paying attention. And then Lauren, you brought up sort of a way of describing it. I thought that really kind of, made it clear what we're talking about here.
Oh, yes. I could talk for days about this. So my boyfriend loves EDM, loud rave music, and I hadn't really gotten into it till recently, but for some reason, I think he's going deaf, and every time I try to say something to him, unless he's looking directly at me and I made sure to get his attention first, he always says what at the end of every sentence I say. And it drives me, our favorite word recently has been bonkers. So it drives me bonkers to, repeat myself constantly over and over again. And, I try not to get frustrated, but it's definitely frustrating when you have to talk over and over again. So I'm very curious, like, is that like something that most people deal with? Is that something just because he listens to loud music all the time and just likes to drive me bonkers? I don't know.
Right.
I've heard it's a common occurrence, but, for me, it's every single day.
But I'm going to just interject really quickly because it wasn't just that. You described it as he would say what, and then you would start repeating what you just said. But before you even started, he would answer your question. So he did hear it.
Oh, yeah. Completely
just
forgot
didn't
about
register.
that part. He
It
does
didn't
hear
register.
me.
So, like, what do you?
Yeah, and I used to
explain that
call
to
him
us,
like
Angie.
I used to tell him that he needed to just start listening the first time, but essentially, like, I'll say something and he completely understands what I said, but still says what, and then as soon as I'm going to ask the question again, he gives me the full answer, like he heard me the first time. And so I'm like, why am I repeating myself if you heard it the first time? But I used to just think it was a reflex for him to say what. And so I don't understand it. I'll do it occasionally, but for him, it's like every other time.
And that's so common, Lauren. This is so great because I have my research and my clinical hat, and I'm going to bring my clinical hat in right now. I'll say about 90% of the time when someone's scheduled to have a hearing test, it's because their partner or spouse brings them in. And the person who's having the test typically doesn't have the problem. So I usually start off my appointments with, I'm happy to test your hearing, but I don't do couples counseling. So after I tell you the results of the hearing test, you can go ahead and find someone for that purpose if you need to. And this happens all the time. I struggle with this even with my own husband. I was irate when I found out he had normal hearing, and I'm an audiologist. So there's a few things that, the best way to explain it is that we have our ears, which are really important for hearing, but our brain's really important for listening. And so although your ears might be working well and in quiet, you can hear a sound really comfortably, you have to have the other processes of the brain actually work. And that's like attention, integrating different sensory components that come in along with the sound. So attaching meaning to it. And so one thing I will say, it's not necessarily pathology. It's the fact that we live in such a distractible, busy world, and we're always on screens, and we have all these different distractions that we're dealing with on a daily basis. So my hypothesis is it could be more about that, our attentional system really trying to help us listen. And sometimes it actually pulls us from what we're doing at the time. So his hearing might be fine, but attention might be distracted. He might be distracted.
So it might be ADHD? Is that what you're saying?
Well, I don't think it's actually pathological. I think it's become more of a normal kind of everyday component of how we listen because of how busy and loud our world is. But absolutely, if someone has something like ADHD or central auditory processing disorders, that can get involved and actually make an impact. And so you might say, well, what does that mean? That means, again, the ear itself, I can get sound to the ear and the sensory part of the ear can respond, but there's something wrong with the connection from the ear to the brain that's being interrupted.
So you're telling me I shouldn't accuse him of selective hearing?
I mean, I think that, you've probably done your own experiment at home and come up with a conclusion from that.
Oh, yes.
But, it's always good to get your hearing tested every year, just like you would your eyes. And I would suggest the same for him, just to make sure that in quiet, hearing is great. It could be hearing in noise or with other distractions around can be more difficult for a lot of people. I will say, Lauren, you mentioned that, you're already using those communication strategies that we recommend with people who have hearing issues. Make sure they're looking at you because we use facial cues so regularly when we're talking to people. COVID was a perfect example of that. Once people with hearing loss had to try to listen while others were wearing masks, it took away those visual cues and made it much, much more difficult for patients with hearing impairment. So...
Yeah, I was going to say there's also, I do have hearing loss, and there's let's say there's the person in your life, let's say, who is a spouse or whatever, who knows you have hearing loss, but still has trouble making the accommodations, speaking louder or looking at you, not like walking away from you as they speak. But it's really normal in our society to just keep talking as you walk out of a room or whatever, and to like revamp all of those things that you've learned or not learned, can prove to be really difficult. But I feel like it's not given the same attention that, like, if you were to say, oh, you're in a wheelchair, well, I'm not going to push you up the hill. I'm just going to, walk right by you. But it feels the same when you have hearing loss, and it's, maybe not given the attention that is due.
I love that analogy. I mean, you can see when someone's in a wheelchair and they may need help. You have the ability to see that without them even talking and letting you know that they need help. You can ask. But when someone has hearing loss, you just don't know unless you know that person well. And so sometimes we interpret that as them being rude because they don't respond to us or they misinterpret what we say. So I think it's really stressful because for patients, part of it is feeling empowered to talk about it and tell people what you need. It's a process. Excuse me, do you mind speaking up? I have hearing loss. I didn't hear what you said. And so there is a little bit more ownership on the individual who's already suffering to be able to make their day-to-day circumstances better.
And especially in the context of what we're talking about today, which is they at least also have cystic fibrosis. So you're piling that on top of another problem. So
Yeah.
I'm glad we're talking about it today, not just that stuff, but how to prevent it and how to deal with it if it's you that gets it.
Yeah, and I'm glad we're diving right into it because we started with, something that is not as maybe serious, but hearing loss is incredibly serious. And, I'm glad that Andrea, you're going to be somebody who's going to really, give us a perspective. And I remember I had a couple of patients, and Angie, we've spoken about them, where hearing loss greatly impacted their lives during a time where they were finding real success with their breathing. And, but without hearing, their life was really, filled with isolation and depression, and they couldn't really benefit from some of the, the healing that had taken place. I will just add one more thing is that we, one of the reasons we're doing this podcast is that we've had a successful webcast in the past. And when we first started that, we didn't think, and actually Zoom didn't have the option of closed captioning, but it took somebody to let us know that they had trouble understanding us, for us to turn that on and to recognize the hearing loss that is present in our community. And so, tell us a little bit about why you were interested or how you became interested in in the CF community, because you were already, on your way to becoming an otolaryngologist, but, what brought you to the world of CF?
That's such a great question. And when I think about this, and this is a story that I always tell trainees because there isn't one path into your career. I did my PhD at the University of Arizona and my clinical degree in audiology there. And my focus was on auditory development. So all of my studies were working with little babies. I didn't know anything about cystic fibrosis. After my postdoc at the University of Washington, I came to OHSU and helped the director of the National Center for Rehabilitative Auditory Research at the VA start his lab. And we were testing these new metrics that were more sensitive to detecting high frequency hearing loss, which is really important for medications like aminoglycosides or certain chemotherapeutic agents, because they start to affect the highest frequencies first. And so if we can detect it early, we can try to prevent hearing loss when it gets to those important speech, perception, listening frequencies. And so while I was working on that project, we actually went to the Cystic Fibrosis Center because it was a cohort we were testing. So there's a patient population I wasn't familiar with, and I'll never forget. The first time I was at the center, I was like, oh, do patients, are they having their hearing tested? And they said, yeah, sometimes, but we don't have a big hearing issue. Most people can talk to us when they're in a room. They don't complain about their hearing. And the more research I did, the more I realized that, what's really invisible is mild to moderate hearing loss. Someone can act completely normal in a doctor's visit, and you wouldn't even know that they actually had hearing loss. And that's typically how it starts. So at that point, I made a huge career shift and really focused on changing the landscape of how we manage hearing and balance loss from these medications, specifically in patients with cystic fibrosis, because there was a need. And although the clinicians all found it valuable, extremely important, they're worried about saving lives. They're worried about making sure patients get to their PFTs and take their medications and make sure their prescriptions go in on time. But there was really nobody to really advocate on the hearing end to make a path for that, for patients to get care.
Yeah. When we first started talking about this, Lauren, this was, again, something that you felt you didn't know much about and something that hadn't been spoken to you by your providers. It is, this is not unusual, but what questions did you have?
Yeah, so growing up, I probably had hearing tests, but really, I don't remember a single hearing test. I don't remember doing any of them. I didn't even know it was an issue for CF patients. I have contacts, so I get my eyes checked regularly, but I've never really had to get my hearing tested. I've never had anyone bring it up to me. So really, as a patient, I'm kind of just wanting to know, like, when should it become a standard part of CF care for adults? I know you had mentioned every year, but no one ever brings that up. So how often should we be doing that? And what should we do if our care team isn't bringing that up?
That's such a good question, Lauren. And we actually, so part of the Cystic Fibrosis Foundation otolaryngology guidelines is to implement some type of what we call ototoxicity management protocol for CF. So ototoxicity is the term that we use for drug-induced hearing or balance loss, so damage to the inner ear. And although there's some recommendations in our national guidelines as audiologists, they're not necessarily feasible for certain clinics. So for example, in cystic fibrosis, patients are coming in for every 3 months for numerous appointments to see numerous clinicians, and just seeing another person is going to be probably burdensome to the patient. So what we did is we developed this expert consensus statement that was published in the American Journal of Audiology, and it talks a little bit about what monitoring for hearing and balance issues should look like when patients are on these treatments. And so if you're a patient who's never received aminoglycoside, but you have CF, the recommendation is an annual hearing test, just like anyone in the general population. We check our eyes every year so we can capture any changes and then determine how fast that sensory system is changing. If you have an IV therapy for example, a lung exacerbation or due to Pseudomonas, then we have more rigorous recommendations for monitoring your hearing. And you should go in at the first prescription, so at baseline before you receive the drug, and then at regular intervals when it's feasible for your schedule, the physician's schedule, while you're on the drug. And then for inhaled therapies, we have a less rigorous recommendation because the drug isn't as concentrated in the system, and so the risk of losing hearing is there, but maybe not as high as if you're getting an IV. So we do recommend having a monthly audiogram or balance test, especially if you're not experiencing symptoms, but you're getting these therapies that we know can affect hearing or balance. The biggest issue we have with ototoxicity is we can't identify who will develop hearing or balance loss. So we don't know. One person might have tobramycin their whole life and never develop any issues, but another person may lose hearing after one course of treatment, which is why we have to monitor everyone.
Right. It's interesting. The reason why, Angie and I know each other so well is because we do research in hearing loss. And, one of the things that, you said that you do it yearly. And I think that's something that even myself, I wasn't aware of, because if you're not exposed to an ototoxic agent, we're saying do it every 4 years, but you're saying every year, annually, which is easier to remember than doing it every 4 years.
Just like a physical, and I'll give you one example. Even if you never get on an ototoxic drug, we have patients with sudden hearing loss from unknown causes, and I can't trace back what, like when it happened, what their hearing looked like beforehand, unless I have a more recent hearing test. And so that's why, the recommendation is every 12 months rather than every 4. And then you can also track age-related hearing loss over time.
How do you make it more accessible? Because, going to a booth for your audiometry is a very specialized place, and often it's not right on campus, and it may be you have to go down, to this building and turn right, and then, patients who are leaving a clinic where they've been for the last couple hours, they may turn left to the garage, and that's it. So how do you make it accessible? How do you make it easy at your center? And what can we do at our centers to make that more accessible to patients?
If you think about the global burden, so there's probably over 140 million people who have hearing loss worldwide, and there's not that many audiologists with sound booths. So we had to get out of the sound booth. And with the advancements in technology, there have been some really cool out in the booth kind of self-testing hearing devices that patients can attach to their computers, use their own headphones and calibrate it. The system will walk you through the hearing test and you can do your own hearing assessment. Now, there are different types of applications you can use. Some are considered better than others, but in the end, it's really about the circumstances, how you set up the equipment, and identifying whether or not you have hearing loss. Even if it's not completely accurate on the amount of hearing loss, your goal is really to see an audiologist after the fact and have those responses repeated. And so what we really want is for those devices to be there just so people can get access to hearing healthcare and then come in and see us when there's a problem.
And so for those who already have noted hearing loss, would those apps be like less preferable? Because I feel like when I go in for my test, I'm in like this chamber, and it seems like it's very, it's always like, to see if my hearing loss has changed from one year to the next. And I'm lucky, once we discovered it, we were able to keep it stable. But I can't imagine that a home test would recreate the level of, the degree of the depth to which they go to get these answers. Putting you in a special room and with all of the padding and all that stuff. So would you say that app is really better if you haven't had hearing loss?
Yeah, I mean, that's a good point. I think the degree of hearing loss does make a difference. So if you're someone who has really severe and profound hearing loss, doing an at-home test might not be as accurate because you're not going to have the best headphones. You've got limitations with sound card and the computer. But even if you have some hearing loss, those apps actually can do pretty well to capture that you have hearing loss. And the accuracy is really going to be important if you decide to get hearing aids and determine, what am I going to use to actually amplify to improve my hearing? That's where you want the audiologist to verify what your real hearing loss, what we call configuration, is in the booth for both ears. If you have normal hearing, you can screen yourself every year using these apps. But once you have hearing loss, you should definitely establish a relationship with an audiologist to track your hearing and determine next steps for amplification and rehabilitation.
So if you have no hearing loss, is it smarter to test yourself at home, or is it smarter to go to a professional? Because I don't know how. Can you walk us through first, before I ask any more questions, can you walk us through how the hearing tests work? If there's a basic test, a more advanced test, I don't know anything about it. So how does the actual screening process work?
Well, I'll start off and say it's always better to go to a professional if you can get in. It's the gold standard. If you can come to the audiology clinic and get tested in a sound booth with all of our beautiful calibrated equipment and high-end headphones, you're going to have the best outcome and result. But again, we have to look at, what's the cost, benefit, and resources? What's your time like? Can you get in a reasonable time frame? So really, the best type of hearing test is to do a screening hearing test for pitches or frequencies that are important for everyday listening and conversation. Because what connects us as people is what our sounds, our environment, and our speech. And so what these tests can do is test that limited range. So if you're going to do an at-home app on your phone, like for example, I know the Apple AirPod 2, I believe, has a home hearing test option in addition to the hearing aid feature. And so you can connect your headphones to your phone through Bluetooth, and it will walk you through the test and say, you're going to hear a tone. I want you to respond if you hear this tone, yes or no, until you stop responding, and it'll determine what your sensitivity is for that given pitch or frequency. And you'll get that for that whole range that's important for kind of speech and language everyday listening. So the apps are really user-friendly. And I would say that's definitely the place to start, is to make sure you have what we call an audiogram, which is looking at the sensitivity of how you can hear low to high pitch sounds important for everyday listening.
Okay. Do you have a favorite app to recommend for someone who's never done it before and has no clue what she's doing?
Especially those who may not be Apple people. There's the Android versus Apple people. So maybe it's something that's not AirPod.
Yeah, so the Mimi Hearing app, I believe, and that's something I should look up, but the Mimi Hearing app's used pretty regularly. I don't know, Ahmet, if you've used that
Yeah.
in your clinic.
I have. Yep.
And it's great because, it's user-friendly again. It can connect to Android. It's not just limited to Apple products. And it has pretty good accuracy. So there's some validation on comparing what the hearing test looks like on your Mimi app, hearing, audiogram to what I actually get in a booth. But of course, you have to make sure the headphones are on correctly. And there's all these little factors that could play a role into how your hearing test outcomes can change.
That's great. Yeah, so we do use Mimi. And I think that, back when we were doing our work and we were screening everybody, we had these really nice headphones in the clinic, connected to an iPad, and it would take 15, 20 minutes to go through all the different testing, beyond the pure tone audiometry you just talked about. But having it in the clinic really made a big difference. So Mimi is the app that we used to also use as we were doing this study, but you feel that is a good app to use, and maybe would you recommend that we do it in the clinic together?
I think if you're going to be in the clinic, the Mimi or the shoebox is probably the one used most regularly. And I know that, Amit, you've done studies with shoebox before. They have some pretty good validation studies. And they've also expanded their hearing tests to test higher pitches that are sensitive to these medications, what I talked about, to look at early signs of hearing loss from these medications. And so the difference between the Mimi and the shoebox, varies in their features, but they're all kind of testing devices. You hand it to the patient or the person sitting in clinic, sitting in a quiet room or in the waiting room, and they can walk through each of the steps with headphones on and conduct their own hearing exam. And then the examiner, or you can have an audiology or tech assistant that can actually interpret the results. The test will give you outcomes about your actual hearing test result, and you can share that with your doctor.
So another thing so I wanted us to definitely talk about, other ways of mitigating risk for hearing loss, and maybe some, future research that you're involved with. But before we go there, I want to take a little segue towards another function of the inner ear and how it helps us with our, our stability. And, one of the things that, we talk about in clinic is your hearing, and are you dizzy? Our physical therapists are really good about, making sure that, we touch on this. And, Andrea, you were sharing that this is something you struggle with. We call that vestibular toxicity. I don't know if you can share your story, and then Angie, can you tell us exactly, why that's the case or why that happens and how it's connected to hearing?
Sure. Well, I had my lung transplant in 1998. I had a lot of tobramycin back when they didn't really know as much about the connection there. So I woke up with a lot of things, and one of them was I didn't know I had hearing loss, but I had it, high frequency. I also had ear and light and sound sensitivity. They were calling them migraines without the headache. And I had a lot of vestibular issues. So, part of me thought well, I've been in the hospital for a really long time listening to bells and whistles. And, I went home that first night and my brain just did a whoop-de-doo, what's going on here? And it took me a while to figure out that I had hearing loss. I thought, these were just sounds and things that my brain was going to figure out would go away. It took me a while to figure out that even just somebody crumpling up, we used to have those shopping bags, those ones, we don't have anymore because they're bad for the environment. Somebody just crunching one of those up could send me through the roof. And then the third was that I love to dance around as part of the way I get my exercise from time. And I also, it's part of the way I just like live, is
I've seen it.
the way I move. So I started getting really dizzy with movement, and it took several visits to get the diagnosis. So there really wasn't a cure for any of it. Like I had kind of passed the point of no return on the hearing loss and past the point of no return on the vestibular issues. So it was all behavioral things that I had to learn. There were a lot of surprises, I will say, that came up after transplant, and they certainly do a very good job coaching you about like you're trading one set of problems for another. But this was not on my radar. It probably wasn't on a lot of people's radars. So it just was. There was just a lot of behavioral modifications that I had to make to adjust to that stuff, and even to this day, it follows me around, and I have to be very careful about adding to it, like the burden and the load that my brain can take gets, I have to be careful with it.
Wow, thank you for sharing your story. I think we have a huge clinical gap in this area to really understand how these medications cause vestibular problems and how to measure it and deal with it. Many people know about hearing, and we've done a lot of work in the hearing realm. So we know when you take certain medications that you may be at risk for hearing loss, but you're also at risk for balance loss because the inner part of the ear is widely connected with the cerebellum and our eyes and our brain. And so if the sensory cells in your ear are damaged, then it actually affects how it connects. There's a reflex called the vestibulo-ocular reflex. So it actually affects how the brain is connecting to your eyes and controlling your vision. So what happens when your eyes are off? You get dizziness. You get something called oscillopsia, where you can't maintain, like certain fixated objects in your environment, and then you can't drive. It's out of all of the things that I've talked to patients about, when we talk about hearing and balance, and they're all difficult, but there's nothing more difficult than the vestibular issues in terms of impacting quality of life and daily functioning. And so I'm glad that you shared your story and that you brought this up. This is something that's not on the radar, I think, of a lot of patients and even clinicians. We think because, we're physicians or, we're a specialist in an area that it's on our radar to understand all of these things, but it isn't the case. So sometimes patients will complain about dizziness, and then they'll send them to their endocrinologist because it's a side effect of diabetes. But, you might think your clinician might not think about an audiologist to get a vestibular test. And
I would say early on, I was sent everywhere, like the Johnny Cash song. I've been everywhere, man.
Mm-hmm.
Andrea, you and I were at a fundraising event, and I was, Andrea, I could tell is someone who loves to dance. I mean, I didn't get to hang out with you when you're younger and before all these issues, but and Andrea is a big fan of Marvel, and you were dancing like little baby Groot when Groot was like sort of stuck in the flower pot. But you were moving, in that very cool way, but you definitely knew that you had some boundaries, or you might actually, fall down.
Yeah. No,
Yeah.
you find your boundaries and you work with them.
And there's ways. The one thing about balance, that even if you lose that sensory system in the ears, sometimes your brain can compensate and things can improve over time. And so that's why we always recommend physical therapy once there's some type of vestibular insult or deficit. But I think the harder thing as a field is that we're lacking in really good measures to make sure that we are able to test everyone who's suffering from this. Right now, if you were to go get a full vestibular test, did you do that in your clinic? Did they send
God.
you?
Just making me dizzy just thinking about it.
Yeah. Okay. So actually, I would love for you just to share with listeners about your experience, because this is really what we struggle with as a field, and something we need to improve.
I can remember. I just remember, it was like one day and several tests, like going into rooms, and there was one black and white checkerboard something or other room, and there was another room where everything spun. It was like being at like some really bad, no offense to the hospital, but some really bad, like where they have all the shoot 'em up games and the
Like a carnival?
Ferris wheel. Yes, thank you. Ding, ding,
You know-
ding, ding. Gee.
Well, you said hospital. I was gonna like. There's so many ways I wanted to finish your sentences, but that wasn't where I
I
was
know,
going.
right? No, I said no offense to the hospital, but it was
Yeah.
like a really bad carnival. But
Thank you, Lauren.
done in all the wrong ways. And
Oh, of course.
I left sick. Like, and my husband actually, they thought he had Meniere's disease. Totally, he doesn't have CF or anything, but when we met, we were like, "Oh, you went through that test too?" And like years later, still haunted and traumatized kind of it by that test. But that was like kind of the only test, and that's where I got diagnosed with, migraines without the headache. But I mean, I'm still like, when things flare up for me, or when I have a lot of, let's say, drugs in the ICU I was in a car accident like 2 years ago. Things with my brain like can flare up and go backwards, and the the vestibular stuff can come up, and there's still no like, the PT. Every PT has their way, and they're all good. Of like, let's get you back on track, or let's have you stand on a foamy thing, or like balance on a ball. And I can still probably, like with my yoga like background, out tree at least a few of you, because I'm, I worked at it really, really hard. But there was no like, okay, well, let's like run you through these like exercises and then score you and figure out where your balance is at or where your vestibular system is at. Like, the most we can do is say it's acting as if it's been concussed. And there's no scale on which to put that.
Right.
I've had the opportunity actually to have that test again in my 40s and my 50s, and I shut that down.
Yeah.
Yeah.
I mean, it's usually when we do a vestibular workup, patients are there for 4 to 5 hours. And our goal is to make people, it's not our goal, but ultimately everyone gets dizzy or nauseous because we're putting, solution in their ears to kind of stimulate their vestibular hair cells. And the problem is that each of those tests only test one part of the system. So you have to do all of them to really understand what's happening. And so we're trying to move away from that. I was telling Ahmet about some work I was doing on balance and CF that's looking at what we call kinematic sensors, wearable sensors, where patients wear these, they almost look like little watches around their body on the limbs, and we can actually measure how they move during different tasks. And that gives us a really nice objective way to see, what is mobility like on a day-to-day basis? Does it impact your daily life? It could be vestibular, it could be a combination of things, but how do we improve how you're actually moving and your balance to make it better for you in the long run?
I was picturing when you said that, athletes and, who want to study their movement in like, with CGI, people wearing green suits and like ping pong balls all over them. So it's something similar to that.
Well, so for this, so the old school way was using those inertial, those IMUs that we call them, but this is a little bit different. So this is actually using these little sensors. So it's just like a watch that goes around your feet, on your arms, on your head, on your torso. And there's accelerometers, there's a barometer and a gyroscope within those, and they all communicate with each other. So when someone's dancing or walking, it can tell you exactly what each limb is doing, how fast it's doing it. When a patient turns around, if you're just walking and then you turned around, how fast was that turn? How often did you use both feet or one foot? And the reason that's so important is because the full body movement and how your torso interacts with the head is really critical for overall balance. And we know as audiologists that with my ears, when I turn my head, I'm stimulating my vestibular hair cells. So anytime you're walking and you're turning your head, you need vestibular input to be able to maintain balance. And so, so those wearable sensors are really cool, and they'll send that information right to a computer screen, and I can see all the values on the screen for each of the walking or balance tests that I'm doing.
So I think what the important message here is that you can use these tools and we can retrain and the person with that dizziness to be able to manage their life and be able to go back to living normally, maybe driving and doing the other things that they do. Is that right?
Well, to some extent, depending on the severity, people should have improvement, absolutely. And it may take time. So we know
Right.
the brain's going to compensate, but every patient's different, and every complication that a patient has, you have to deal with other things going on. So if you have cystic fibrosis related diabetes, maybe there's a movement disorder along with CF, along with
Yeah.
the drug-induced hearing loss. And so it can get really complicated. But in the end, I think the proactivity piece of going to get rehabilitation, you should see some improvement over time, at least for most patients.
Yeah. And I want to just share one more thing. And this is research that Angie and I need to write up together. So hopefully we're going to do that. But just so that you're not afraid if your doctor wants to start you on a medication like an aminoglycoside, we are monitoring and making sure that levels are not reaching toxic levels as much. Before we had a monitoring system that wasn't as precise, and now we do individualized pharmacokinetic, and that is a fancy term for saying that we're monitoring it so that it's not a one size fits all. It is, like a dose that is set for you. And one of the, outcomes that we saw that we didn't see the type of hearing loss or hearing risk that we used to see. And interestingly, we saw it with drugs that we didn't have that type of monitoring for. So hopefully we're going to be publishing that, but I just want to make sure that you know that there's a lot more that's being done. So when we're trying to treat your infection aggressively, we're also paying attention to your hearing. And most CF centers are doing this, is monitoring the levels more appropriately.
Yeah, and also, and so that's a good objective clinical way. And I was going to say it's so important for patients to also be their own advocates in the sense that, Andrea, you mentioned a symptom that I don't know if a lot of people are familiar with. It's a sound sensitivity. And we actually have a term for that called hyperacusis. And so sometimes when patients have these ototoxic related symptoms, they report things like sound sensitivities, tinnitus, ringing in the ears. But hyperacusis is also a common one that is not measured in the clinic. So those are things that the patient themselves, it's a subjective sound quality, the way you interpret sound. It's important to let your doctor know that you're experiencing that because it could be a symptom related to this, to ototoxicity of your therapy. And not everyone's going to have it. So again, we just don't know who will develop it and who won't.
I will say, in terms of advocating for ourselves, when I first met Ahmet and found out that there was a place where I could talk about ototoxicity, and there was a way to look out for it, that it was like connected with a bunch of doctors who were interested in looking out for it. I started they give you a dose of vancomycin, for example, right before surgery. And there was one time where I was like, nope, you're not touching me with that. And I think they called Ahmet from the surgery room. And they were like, your patient here is refusing to have a dose of vancomycin.
And I'm
And
like,
he
I
had
don't
to
know her. I don't know.
Yeah, he was like, Andrea who? No, they had to explain. They explained to me it was okay and we're going to be okay. But I was really scared to lose. I felt like they explained to me. I was like just on the cusp of. I had tinnitus and hearing loss, just on the cusp of. If you lose a little bit more, then you're going to land into conversational hearing loss, and I'm probably a little bit there now anyway. But I was pretty protective of it, apparently.
Well, maybe that's where we can pivot right there. And Angie, you can talk about what are some things that people either can do now or there's research, that you're working on of ways of trying to prevent, toxicity from these agents or hearing loss in general.
Well, so the first is definitely looking out for symptoms and letting your physician know as soon as you're on these therapies, they are doing wonders to help your overall lung health. And sometimes we don't know that they're affecting your balance or hearing unless you tell them before you have a hearing exam or a balance exam. Secondly, I think we highly underestimate noise control in our environment. We live in a very, very noisy world. I'm in some ways a horrible audiologist who goes to concerts all the time and I love things loud. But in general, especially when you're on these medications that can cause inner ear hair cell loss, you're even more vulnerable around loud sounds. So one thing you can do to help protect your hearing is keep the volume at a reasonable level. I always tell people if they have headphones on, AirPods, or whatever you're listening to, if the person that's in the room with you can hear it, it's too loud. And so volume control is a really, really big key component, and particularly when you're on therapies that can affect your hearing and balance. We have some really cool novel medications that are now being in their phase clinical trials that we're hoping will eventually help prevent hearing loss while you're receiving these therapies. But there's really only been one that's gone to market, and that was really for pediatric cancers. It's called sodium lauryl sulfate. And so that seems to help while a patient's on, cisplatin, for example, chemotherapeutic, they can take this ototherapeutic drug to protect their hearing so that cisplatin can do its job and help with fighting the cancer, but the ototherapeutic will help protect their hearing. And we do have drugs that are currently being developed for aminoglycoside specifically, like tobramycin or amikacin, that are given to patients with cystic fibrosis.
So
I'm
go.
gonna
There it
leave,
is.
and my pump's just going to stay.
That's
for the
it.
rest of the
That's
episode.
it. That's the sound.
I was trying to figure it out too.
So just so people in our audience knows that we just paused for a minute to be able to acknowledge the sound that you've been hearing intermittently throughout our podcast. But it is absolutely appropriate for us to bring it up because it is so apropos to our conversation. Andrea, do you want to tell us what's been going on?
Well, it turns out I have CF-related diabetes, if you all haven't checked out episode 2. And my alarm's been going off that for some reason my insulin has stopped. And it's a high-frequency alarm that I was not able to hear. So our engineer, Courtney, was kind enough to let us know it's been going off for some time. And I'm mortified, but I'm also, we're going to use this as a teaching moment that, this is what happens.
And Courtney may have saved your life because you weren't getting insulin. I'm just kidding.
Well,
I
yeah,
know.
she did. Courtney's already saved my life.
I
a
gotta
few
always
times
watch what
on
I
it.
say.
You don't know.
I gotta be
You have
careful.
no idea.
And don't forget that I also have a pump, so it could have been me the whole time too, and it could have happened to me
Yeah.
too. So who knows? In future episodes, it might be me. Who
But
knows?
it was Lauren who actually figured out what might be the culprit here. So yeah, our
It
two
sounded
diabetics.
very similar to mine.
Yeah, it's a really amazing that that product is that high frequency, and so I don't know if there's a vibration option, but that's pretty critical there, and so there may be other ways of
there is a
doing it. Yeah,
vibration option, but it's so tiny that
you can't feel it.
sometimes you don't feel it. But
Yeah.
I didn't switch it over, and so my bad. But
No, but I mean, I think it also allows us to come up with another question that we have for Angie, and that is technology. Now the FDA, and see how I'm bringing that in there? Actually, it's not that. It's not that
So
ingenious.
smooth.
It's really not smooth. We're going to work on the smooth. But the FDA in 2022 has ruled that you can get a hearing aid without a prescription, and thus there are products out there. And we talked about one, AirPod. But what are some technologies, or can you talk about that? What has changed in the landscape? I mean, 40 million people, you said, have hearing loss, and that's for those who know. How is that changing the lives of people with hearing loss?
Oh gosh, it's such a good question. And again, like I said, there's just not enough audiologists and hearing aid specialists to go around. The other big issue we've had is that the cost of hearing aids are astronomical, or they have been traditionally, and there hasn't been an insurance benefit. So most people who are getting hearing aids are middle to upper class that can afford a digital $3,000 to $6,000 pair to be able to help improve their overall hearing and daily quality of life. So what's cool is when the FDA passed the 2022 ruling is that it didn't require a prescription, and you could actually obtain an over-the-counter hearing aid online. And so there's a number of different companies and features. And you know, what I typically tell patients is that they're not necessarily going to be the same as when you go see an audiologist and get a nice $3,000 to $6,000 digital pair. There's a big difference there. These are mini computers that you put in your ear, and they're programmed to exactly where your hearing loss is. However, it really depends on that person, their quality of life, the activities that they want to do. And so I always suggest try it before you buy it, and see if you do see that benefit, because you may have that hearing loss and a lifestyle to where you're getting just enough benefit that it does help improve things. Some of these hearing aids are only $200, $100 to $200 offline. So, but I wouldn't expect a miracle, and I definitely would not expect to be able to hear better in noisy situations. I think that would be the most difficult component to it.
So you get what you pay for a little bit. So the price might be like at a price point where you can afford it, but you may not get a lot of the benefits we might see with the more expensive products.
Right. So the more expensive products, some of them have multiple microphones, and the microphones are really sensitive, so that if you're in what most people with hearing loss complain about is when you're in a situation with noise, you're in a restaurant, you're in a bar, you're, at a ball game, it is really difficult to hear the person you're talking to. And having any type of amplifier in your ear is never going to be like natural hearing, but we're getting much, much better at actually improving the ability for people to listen in noise. And so the microphones that are put in those hearing aids are designed to reduce the background noise and really focus on the person that you're looking at, and amplify the sound coming from the front of you. So some of the over-the-counter devices may have some aspect of those features, but the technology typically isn't going to be as advanced for the price. And then you have other things like durability and what happens if your hearing aid starts to have issues. Who do you send it to? Who cleans the hearing aid? There's a lot of what ifs. But one thing I want to say is I personally am an advocate for over-the-counter hearing aids, or sometimes you'll hear the term PSAPs for those, because they at least provide an option, a path for people that would not necessarily have been able to see an audiologist or afford their own hearing aid.
No, I think absolutely necessary. And I mean, there's so many things and we have so many things that we want to talk about that we haven't gotten to talk about. And so I really feel like we're going to need another podcast to really dive into it and go deeper. I mean, because today I think we were able to touch on some of the basics, some of the testing. We didn't go through all the testing. You alluded to them, but I feel like we're going to have a part 2.
Sounds great.
But how we end our episodes, and I don't think we told you about this, but this is a little game that we like to play, where we ask you some rapid fire questions. And I might have Lauren and I may go back and forth, and Andrea might chime in with some of the questions, and so we may go back and forth. But if you're ready, we'd like to learn a little bit about you. All right. Best way to cut a sandwich.
Perfect.
Diagonal into triangles or midline to create 2 rectangles.
Oh, diagonal.
Love it. Go ahead, Lauren.
Early bird or night owl?
Oh, night owl. I'm horrible in the morning.
Pedro Pascal or Timothée Chalamet?
Ooh, Timothée Chalamet.
Do you use subtitles?
Yes.
Sweet or salty?
Salty.
She's good at this. She's really fast. Do you believe in ghosts?
Yes. And I have stories.
You might need
that might have to be another podcast.
Marvel or DC?
DC.
Favorite snack?
Oh, gosh, chips. To be specific, salt and vinegar.
I'm going
Good
ready.
choice.
True or false? Ahmet painted the mural behind him.
True.
True.
All right. Yeah.
Is it true?
Did
for
you
real?
paint that
It is.
mural?
I did.
That's amazing.
If you had a close up, you wouldn't say amazing. It looks good on a camera.
He's also humble.
It's pretty talented. Yeah.
No way. And I think that's all I have. Andrea, did you count up the points and see how many points Angie got?
Yes, Angie has 6,945 points. I can't say whether you're the front runner or not because I'd have to go and check my math on the other games, but that's where things stand right now.
Well, Angie, thank you so much for being here with us. And we did have a little technical difficulties. We'll share it that in the beginning we had some issues with our microphones, and it was very, again, apropos to our topic today. So thank you for going with the flow and joining us, and we look forward to seeing you again.
That was a wonderful invitation, and it was good meeting everybody. Thanks for having me.
I'm just going to ask this. Did you want to take a crack at singing It's a Long Story?
Oh, you don't want to hear me sing.
Have you heard, have you
we
heard
do.
the opening song? No, that's not true at all. We want to hear everybody sing. We're going to do at the end of this series.
Ooh,
We're
I
going to
that. This is new. Andrea
we're going
just thought of this. I like
we're gonna
this.
string together remember I like to buy the world a Coke, I
Does
don't know.
Angie,
Okay, so here, I'm just
maybe
gonna
can
play-
we here just play our little jingle?
Story, Joe's story, is it just an allegory? Show's about to start and we still don't have a name for it. Bop, 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 bop. It's a long story.
So we start every episode with singing "It's a Long Story." So
Bop, 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 bop. It's a long story. That's all I got.
That was perfect.
You did it.
that was good.
Okay, so now I want
no
to
glasses shattered over here. We're good. So Angie, thank you so much. Really appreciate
Yeah.
you being here, and it's also short notice. So we're
That's great.
grateful to you.
Until next time.
Get a little older.
Live a little bolder.
Bye, everyone.
Boom.
We are working hard to provide meaningful information to a deserving CF community, information you won't find anywhere else. If you'd like to help us grow, we'd greatly appreciate it if you would follow us on Apple Podcasts, Spotify, or wherever you get your podcasts, so you never miss an episode. Want to go all in? Leave us a rating and a review. It helps people find us and makes a big difference. If you found this episode helpful, please share it with a friend, family member, caregiver, or provider who might also want to hear it. This helps you, it helps them, and it helps us spread the word to those who need to hear it most. It's a Long Story is produced by me, Andrea Gavin Becker, and is hosted by Dr. Ahmet Uluer and Lauren Harvey. Additional editing and production support is provided by the team at Resonate Recordings. Until next time.
Get a little older.
Live a little bolder.